Hello, good afternoon, and welcome. Really delighted to welcome you to this event hosted by the Ontario Network of CAPCHP projects. Today, we are supporting maternal mental health with presentations that we're really excited to share with you. Voices from Practice and Systems. And my name is Sydney Bell. I'm the network program lead. And again, just really happy to welcome you for our event. We're just gathering here in our Zoom room and about to introduce our speakers to you. As we begin, I would like to take a moment to acknowledge the many territories across Ontario where network members are joining from today, and the longstanding relationships that First Nations, Inuit, and Métis peoples have with these lands. Our Ontario network of CAPCHP projects, the sponsor agency who I work for is Camino Wellbeing and Mental Health in Kitchener, which is located on the traditional territory of the Haudenosaunee, Anishinaabe, and Neutral peoples within the Haldimand Tract. And so today we'll be having two speakers talking about maternal mental health, and Blanca will be introducing them to you. And before I pass you over to Blanca to welcome our first speaker, I just want to give you a heads up that near the end of the session, I'll be posting a link in the chat to a really quick, literally 2-minute a 2-minute event survey that I hope you'll share your thoughts on today's session. So I would like to hand things over to Blanca Serrano from Public Health Agency of Canada to introduce our first speaker. Blanca, hello.
Hi, Sydney. Thanks so much. Thanks everybody for joining us today. And today is actually May 6th, the World Awareness of Maternal Mental Health. I saw someone that had the background and they had the World
They
Maternal Mental
do.
Health. There
Sandra
it is.
does.
Sandra has the World
Hey.
Maternal Mental Health Day background. So today, all around the world, there are different activities going on. I know Ontario, Canada, has various activities to ensure that we raise awareness about the importance of supporting perinatal mental health and support to moms. We know that perinatal mental health disorders are the most frequent complication of childbearing, and yet many times these go overlooked. And the risk is isolation and lack of support for moms and their babies. So this is why this is so important that we're together today, and thrilled to have the two speakers. And I'm gonna go ahead and introduce Sanober. She's our first speaker. Let me just pull up her bio here. Sanober Diaz has served as Executive Director of the Provincial Council for Maternal and Child Health since 2020, with experience spanning management, consulting, government policy, and hospital operations. She brings strong expertise in strategic planning, quality improvement, and large-scale system change. Previously, she held a leadership role at Sunnybrook Health Sciences Center, overseeing specialized ambulatory care programs. Sanober is a collaborative leader committed to advancing health equity and strengthening partnerships to support healthy pregnancies, children, and families across Ontario. She holds a Master of Health Administration from the University of Toronto and is a certified health executive. So welcome, Sanober. We're thrilled to have you today and learn more about your work at the council.
Thank you so much, Blanca, for that introduction, and really wonderful to be here with everyone today. I'm just going to do a quick check once I share my screen in full, and maybe Blanca, you can let me know when you're able to see
We
my
see it now.
presentation in full screen. Yeah?
Yep.
Okay,
There
there it is. Yeah, no, that looks good.
Okay, perfect. Thank you, first of all, so much for having me here today. Really delighted to meet all of you and have this conversation. I do have some slides, and I'm going to go through them over the next 20 to 30 minutes. Just wanted to invite folks, if you've got questions, but also if you've got comments or reflections or personal experiences from your work that you want to share, then please do put them in the chat or raise your Zoom hand as I go through the presentation. I'm happy to make this interactive. I know that Sydney did offer a land acknowledgement. I wanted to start by just acknowledging that I'm coming to you today from downtown Toronto, which is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe peoples. And I just want to express my gratitude as a settler for the opportunity to live on this land, to work here where the PCMCH office is located, and to raise my family. This picture is obviously not from Toronto. I think some of you will probably recognize this as Flower Pot Island in the Bruce Peninsula, Hudson Bay area. Just beautiful area of Ontario there, if any of you are from that part of the province or have visited. So this is a picture I took a couple of years ago on a family trip. And I shared this today because it's a good reminder, at least for me, of the beauty of the land and the Dish with One Spoon treaty between the First Nations many, many centuries ago, which is a reminder to be good stewards of the land and only take that which we need, and to think about the future generations that are coming after us. So I do also want to, on behalf of PCMCH, recognize that Indigenous practices of health and well-being have been in place since the beginning of time, and PCMCH is committed to honoring those practices and learning about them. We are also acknowledging the harms of the past and committed to doing our part when it comes to addressing the calls to action from the Truth and Reconciliation Commission. Probably don't need to share this with this particular group, but I do want to talk a little bit about perinatal, newborn, and child health. My presentation is split up roughly equally in two parts, talking a little bit about PCMCH, the Provincial Council for Maternal and Child Health, and our work more broadly, and then talking a little bit more specifically about perinatal mental health. So just to kick us off here, the whole pregnancy period, infancy, early years, that's a very critical time of rapid development in people's lives. We know what happens in the first 1,000 days of life, starting at conception and in the first couple of years of life, and even further out into early childhood, has a lifelong impact on people's health and well-being. So it's really important for us to think about any needs that these populations have, and be able to support them and address those needs in a timely fashion to make sure that they're set up for success as they go through the rest of their lives. These particular populations are quite vulnerable. I think it's fair to say that newborns and children, they don't have the ability to always advocate for their needs, and they're completely dependent on caregivers and the systems around them to have their needs met. That creates a certain vulnerability. Even pregnancy is such a period of transition and can be such a vulnerable time for an individual going through it. Not just all the physiological changes, but also thinking about the life changes, the significant changes in their family that are ahead. And I think it's important to recognize the important role of social determinants of health when it comes to setting up pregnant people, new parents, babies and children to really thrive in life. The last point here, I like to talk about this, particularly when I'm speaking with my colleagues who are quite focused on health system sustainability and ensuring that our public healthcare system is run well. There's a strong argument to be made that if you invest in good maternal perinatal care and good early childhood care and other interventions, that definitely pays off in the long run. These people grow up to thrive, be healthy, and and use less healthcare, if you will, and cost less to the system. So there's definitely that financial argument that can be made, but also our communities do better overall, and overall population health is better as well. Now, this slide, I called it Ontario's Perinatal, Newborn, and Child Health System, but I fully recognize that we don't have a singular system. On the left-hand side, we've got the map of Ontario, beautiful province that we have with its vast geography. We've got some very densely populated urban centers like where I am today in Toronto, surrounded by all sorts of office towers and giant condo towers. We've got the sprawling and ever-growing suburbs. We've got more rural parts of the province, more remote communities. We've got the far north communities, some of the communities that are fly-in certain parts of the year. So it's important to recognize that there is variation in access across different parts of our province. We're also one of the most diverse places in the world. In the last census, more than a third, I think something like 34% of Ontarians identified as racialized. So all this to say, there's rarely going to be a one-size-fits-all approach to a lot of the complex health issues or health and social services issues that we tackle. And we need to recognize and appreciate the diversity of our population and think about how we come up with solutions that are customized to the needs of different communities. On the right-hand side with the colorful bubbles, these are the different components of the system. We've got the parts of the healthcare system like hospitals and primary care and community home care and so on. But we've also got a few bubbles here that are really important to emphasize. And that's community services, social services, the education sector. All of them play an important role in ensuring that people, young people, children, pregnant people, families are healthy and to support their well-being. And there's a lot more. I could have dozens of circles on this outlining every single part of the system. So it's not really intended to be exhaustive, but simply to illustrate that we've got a system that is can at times be siloed and has a lot of different parts. And it's really important when we're talking about things like perinatal mental health to really try and move forward as a system as a whole. I am seeing a couple of comments come in, but I think those are just welcoming folks, so I'm going to ignore them. So probably Sydney and Blanca, you'll unmute and cue me if there's a question or a comment in the chat.
Yes, we'll do that. We'll do that, Sanober.
Okay, great. So I want to talk a little bit about PCMCH. PCMCH stands for the Provincial Council for Maternal and Child Health. PCMCH was set up by the Ontario government about 18 years ago in 2008 with the mandate to provide evidence-based and strategic leadership for perinatal, newborn, child, and youth health services. I just wanted to note that we've got the word maternal in the name of the organization, but you'll hear me refer to, instead of using the term maternal, I'll primarily be saying perinatal. And as we have learned and evolved as an organization, we've done a fair bit of work around inclusivity and paying attention to the language that we use. So saying pregnant people or pregnant women and individuals and talking about perinatal care as opposed to maternal care is our effort to be inclusive and recognize that not everyone who's going through their pregnancy journey may necessarily identify as a woman. And so we wanted to make sure that that the language in our resources and in our conversations is reflective of that. I also want to make the point that when the government created PCMCH, it was very intentional to have a singular organization that addresses both perinatal health as well as child health, recognizing that the two are so interconnected, and we really need to think about how healthy pregnancies and healthy births lead to babies growing up to be healthy and growing up to be healthy children, healthy young adults, and going on to live their lives as they're fully grown. So with this broad mandate, Here's our mission, vision, and values. Our vision at PCMCH is to ensure the best possible health. This is what we want to see, is the best possible or optimal health and wellness for all pregnant women and individuals, newborns, children, youth, and their families in Ontario. One of my obstetrician colleagues likes to say, we want to be the best place in the world to have a baby. And I would say we want to be the best place in the world to raise your family or to grow up. So really that's what we're striving for. And how we translate that into the mission that we're pursuing is with a focus on health outcomes and reducing inequities. We're doing that by being effective leaders for the system and by being good partners, by trying our best to be responsive to the issues that are shared with us and highlighted to us by the partners that we work with in the health system and other providers outside the health system, as well as patients and families and members of the public, really having a keen understanding of the issues that are facing the perinatal and pediatric population across the province. And being driven by evidence and relying on good, sound evidence is very important at PCMCH. That's one of the key ways that we demonstrate the objectivity and impartiality of our resources. And we find that that's been a real driving force in ensuring that there's good uptake of the work that we put out, working in partnership with many, many experts across the province. This is a summary of our current 5-year strategic plan. I won't go through everything in detail, but I'll quickly summarize that we've got 3 strategic directions at a high level at PCMCH, and underneath all of them, we have a series of strategic objectives that we're pursuing. So on the left-hand side, driving system improvement. This is really about identifying the big pressing issues, I would say, perinatal mental health, infant and early childhood mental health, and youth mental health are big areas of concern across the system right now. There's a whole bunch of other issues I could list off, but being able to understand what those big pressing issues are and then bring together the relevant partners and relevant sectors to be able to take some concrete action to address those issues is a big part of our focus under that particular pillar. In the middle, using evidence to enhance excellence in care is our recognition that there's a lot of great research that goes on in Ontario and outside. There's lots of innovations in clinical practice and new and better ways of doing things, new information that's telling us whether some practices are obsolete and no longer needed, or whether certain practices are outdated and there's better, safer ways to do certain things in clinical settings that are going to lead to better outcomes, a better patient experience. So this pillar is all about making sure that we are supporting healthcare providers with the best information in ways that is accessible for them and easy for them to translate into their practice to make sure that they're staying current when it comes to the delivery of perinatal and pediatric care. And then on the right-hand side, guiding the system through influence is really a recognition that we don't have a singular system. We have multiple different systems. We have different sectors, sometimes with funding coming from different ministries, and it's so easy to get siloed. But we need to keep our eye on the shared goal that we have of reducing inequities and trying to achieve the best possible health outcomes, ensuring there's access for all Ontarians across the province to good perinatal, newborn and child care. So this is about unifying the sector and driving towards our shared goals. I'm just going to show on my last slide where I talk a little bit about our work, a few examples. This is just for illustration to show you what exactly we do. I'm talking at a pretty high level about our goals and our vision and mission, but just to make it very concrete, the sort of work that PCMCH does. Typically, I would say our work falls into 2 big buckets. One is to work with government to advise government on health system planning, where there's needs for investment in particular areas within perinatal and child health. We're doing that. Where there's updates to policies that are needed, we're working closely with government as a key advisor particularly for perinatal and pediatric populations. So you'll see things like, policy recommendations and things like that coming out of PCMCH. We also do work at the system level to support better coordination. This is where we do things like designating levels of care for all hospitals where people give birth in the province and all hospitals in the province that have a pediatric inpatient unit, to help them know what types of patients they can safely care for, what the expectations are for them in terms of the types of competencies, resources, et cetera, they need to have in place to be able to support those patients. And more importantly, know when a patient walks through their doors, to recognize that, hey, this patient may be better served somewhere else where they have a higher level of care, what we call levels of care. So that's another example of some of the system planning work we do. Then we've got a lot of work that we do to directly support individual healthcare providers. And PCMCH works along the full continuum of care. So we're definitely very interested in supporting primary care providers, recognizing not everyone in the province currently has a primary care provider, and hopefully that changes with all the attention and resources that are being directed in that space. But we know that primary care a lot of times is the first door that patients and families are going to enter. So we want to make sure that there's good resources for them. They're armed with the knowledge that they can act on pretty quickly, recognizing that they're busy. But also we're working in some areas that might be quite specialized. So we might be doing some work focused on emergency departments that are supporting pediatric patients, or working on one of the resources here is around RSV. We do a fair bit of work supporting children with medical complexities to make sure that their care is well coordinated, because while this is a small percentage of the pediatric population, they have very high resource needs and often are seeing a lot of different specialists and other care providers. So making sure that their care is coordinated, they've got a high quality experience navigating the system is something that we fund and support out of a program called CCKO. And then we have increasingly over the last couple of years been putting out some resources for patients and families and members of the public. We don't do a ton of this work. Typically, our work has been really to support the system that's working with patients and families, or to support government. But in a few instances, the last couple of years, we've recognized the need for some high quality, evidence-based resources that are accessible, that are designed with plain language in mind and translated into multiple different languages, for patients and families to support their care decisions and really to empower them as they're navigating the healthcare system. So the example here is the third one here that's got the image and a few more colors and more pretty looking, is to support parents in decisions around RSV immunization for their babies, and how to go about making that decision on immunization, answering some of the key questions that often come up. So I'm going to, yeah, go ahead.
Excuse me, Senator, there is a question in the chat from Lee about father inclusion. She says, are fathers included in the supports offered and or involved in a joint effort of support to the mothers? If so, how are they acknowledged, involved with the idea of being inclusive?
Excellent question. Love that question. And I will say, I'll give you an example or two of ways that we're trying to be inclusive of fathers and caregivers, but also will acknowledge that there's lots more that we should be doing at PCMCH. So these fact sheets, as an example for RSV, are geared towards parents who are going to be having babies or have newborns on the RSV front. It's not necessarily just for mothers, it's for mothers and fathers as well. And really it's to help them make informed decisions. When I think about some work we've done on gender affirming pregnancy care for 2S LGBTQIA populations, one of the big areas of focus for us was to recognize that not every person who gives birth will necessarily identify as a woman. So that's part of the reason why we've shifted our language. But also part of that is to recognize that their support person, their partner, might look different than what people might expect in a heteronormative, cisnormative context. So supporting healthcare providers to have those conversations. I have a slide about it, and I was going to talk about it at the end, but I think this is relevant to just acknowledge that people who are working with the mothers or taking care of babies are going to come from all different perspectives. And even when I think about another form that I'm going to reference later on called the Ontario Perinatal Record, which tracks the pregnancy journey, healthcare providers use it to track the prenatal care of their patients. There's space there to document a bit about the partner, if the baby has a father or has a second parent other than the person giving birth, um, their preferred pronouns, some of those extra details to make sure that there's that inclusivity. But those are just a couple of comments that come to mind. But I can offer more if there's any follow-up questions. Even as we're doing more work to include people with lived and living experience, it's been very important for us on some of our pediatric committees and tables to make sure that we've got both youth and parents/caregivers, and that could be parents that are either mother or father, or sometimes we also recognize that the caregiver may be somebody different than the mother or the father. That's also heavily involved in supporting that child or youth, and their perspectives are also relevant.
Sanober, I also got received a question at my end. Are you in any collaboration or working with Families Canada?
No, I'm going to write that down. I must confess I'm not familiar with Families Canada, but whoever raised that, if there's anything you are able to share, I'm happy to hear it now, but I'll definitely, after the presentation, go Google that.
So Families Canada is family support national body, and they put out lots of resources, training for the family support sector.
Okay.
If the person that raised the question has any other questions, we can do that at the end as well.
Yeah, that's very helpful. Thank you. Definitely, we work very much in partnership with a lot of different organizations. On our committees, we have hundreds of volunteers, experts, both those who come with lived experience, families, caregivers, parents, but also clinicians, researchers, practitioners, administrators. And we're always learning and wanting to connect with new organizations and new people. And particularly if there's organizations that are already doing great work, PCMCH often will recognize that there's no need for us to duplicate the work that's already happening. If there's good resources that are out there, sometimes our role is really to showcase them and amplify the voices of other organizations. So thanks for that suggestion. I'll definitely take a look at Families Canada. So I'm going to switch gears now. I'm not seeing anyone else unmute. I will switch gears and talk a little bit about perinatal mental health, recognizing that it is Maternal Mental Health Day today. I have a couple of slides just with a bit of data about the prevalence of maternal mental health concerns. And I want to just start by saying we say maternal mental health or perinatal mental health, but from my perspective, it's not just a health issue, it's really a broader societal issue when we think about perinatal mental health, because we know there's immediate impacts. There is research to show that maternal mental health can create a risk for low birth weight and preterm birth. We know that there's implications for the recovery of the mother or the birthing parent. There can be potential implications for infant mental health if there's some challenges with the infant parent attachment and some of the cues from the baby around their needs might go missed. That can create a risk. There can be significant implications for child development. And often the mothers and birthing parents, babies, they're all operating and living within a broader, often family with other children, often within broader communities. And so it's an issue that affects other people as well. And all this to say, it's a really growing issue. It's an important issue that, from my perspective, certainly deserves a lot more attention, focus, resources than we have in the system right now. But I will, with those comments, I will talk a little bit about what we're doing at PCMCH, and hopefully that'll spark a bit of conversation as well. So this graph is from a recent report that was put out by Born Ontario, and it shows the prevalence of pregnant women and individuals in Ontario who have reported a mental health concern. So in 2023-24, that number was more than 22% for all mental health concerns. And if you look at the number, that's the orange line at the top of the graph. All three lines are growing steadily. One line is showing anxiety, one is showing depression, and the orange one at the top, is showing all mental health conditions. And just 12 years ago, that number was a little less than 14%. It was 13.5%. So we've seen a significant increase year over year in the prevalence of perinatal mental health concerns. And some of it might be because there's more self-reporting, and maybe we've done a better job with addressing some of the stigma around mental health, and that's leading to a greater number of diagnoses. But at the same time, we know that mental health is a growing concern, not just for pregnant people, but for many other members of our communities. And so these numbers are just validating that. This other graph I wanted to put up as well from the same report. And this, again, with the lines going up in trend over a 12-year period, is looking at mental health concerns reported by pregnant women and individuals who have reported that they're using substances. And some of these numbers, if you look on the left-hand side, were quite high to begin with and have just continued to climb up to very significant levels. So substances here includes alcohol, cannabis, smoking, opioids, including prescriptions, illicit substances. So anything that a pregnant person would have reported exposure to, they would have been included in this number. And of that population, if you look at the red line at the top, that's for pregnant people under the age of 20 who have reported using substances. That number is around 64% today. Reason why I wanted to share this graph from that report, and I've got the source at the bottom. I encourage you to go take a look. There's a lot of other great information in that report. Is just to recognize that perinatal mental health is a complex issue. It's multifaceted, and there's a lot of intersectionalities that we often need to consider. I talked a little bit about social determinants of health. Even with the use of substances, sometimes people might be turning to substances to cope with their mental health concerns if they're not getting the other supports that they might need. And so we really need to recognize that change and improvements require action at multiple different levels, at the policy level in terms of just pure investment in the system, and then in terms of having good resources and supports for healthcare providers and as well as people who are navigating their pregnancy journeys. I'll talk a little bit about some work that PCMCH has done over the last few years, particularly around the establishment of a care pathway for the management of perinatal mental health. So a few years ago, we put this out in 2021. A few years ago, we recognized that we were talking a lot about perinatal mental health, but there wasn't really in the system for prenatal care providers a resource that they could easily go to really support their patients in asking the questions about their mental health and being able to explore that a little bit further, and then know what they can do to help their patients and where they might be able to refer them, or some other resources that they themselves as the primary care or prenatal care providers might be able to utilize to better support their pregnant patients. So what we wanted to create was a provincial framework for shared decision-making that would support timely identification, recognizing that early identification is really key to make sure that these pregnant women and individuals get the supports that they need in a timely manner. And we also, as a provincial organization, wanted to put out a resource that could be adapted locally across different parts of the province, recognizing that there's going to be unique community needs and different sorts of supports that may be available. So we wanted it to be adaptable from that perspective. What we did was create a care pathway with 5 steps, and I'll show you an image of that on the next slide, where healthcare providers have a tool to ask about their pregnant patients' mental health, to advise them to be able to assess using some validated tools how their patients are doing, and then really importantly, be able to assist with some supports and resources and to be able to arrange follow-up or referrals and connections with others who would be suited to support them, and then make sure there's a bit of a feedback loop there for that prenatal care provider. So on the left-hand side here is the care pathway. It's 2 pages, and I've got a QR code for this at the end of the presentation, so I'll encourage you to take a look at this. I do want to acknowledge the leadership of some of my colleagues who really undertook the work to create this pathway. It was Dr. Cindy Lee Dennis, who is a professor in the Faculty of Nursing at the University of Toronto, Dr. Simone Weigod, who's a psychiatrist at Women's College Hospital, and Laura Zahradine and Brittany Groom, who are senior program managers and nurses who work at PCMCH. So really grateful to them for all the work that went into putting this resource together and really making sure that it gets out there to different users across the healthcare system and other related systems and sectors that may be interested. On the right-hand side is the cover page of our more detailed guidance document that we have put out that really helps the healthcare providers get a bit deeper into each of those steps. We wanted to keep the pathway pretty high level, thinking if people want to print it and stick it up on their wall in their clinic, or if they want to embed it in their EMRs as a placemat that they can click on and refer to when they're in the middle of a clinical interaction with the patient. We wanted it to be, we didn't want it to be unwieldy to go through, but the guidance document really provides a lot more detail. These are some examples of local adaptation of the pathway. And so I'd encourage you, if you're curious, to go take a look and see how other regional organizations and local organizations have been able to take the pathway, and really where we have links and resources that are provincial, because as a provincial organization, we wanted to make sure that whatever we were putting on the pathway at a high level would be available to everybody across the province and would be part of the publicly funded services that are out there. There are a lot of great organizations and programs that are available locally, so we wanted to create the pathway that could be adapted, and that's exactly what's happened here, where organizations and networks have taken it and really populated it with links that would be more relevant for care providers within their regions. One of the things that we've struggled with a little bit is evaluating the uptake and the implementation of the pathway. At the end of the day, we're putting out these sorts of resources because we want to make sure that care is more readily available, and it's ultimately leading to earlier access to services and better health outcomes. So we did try a couple of times to conduct some evaluations. We look at things like how many clicks we get on our website, or how many times we're receiving inquiries about our resources, including this pathway. But it's been a little bit challenging to figure out the extent to which it is being used, other than when organizations are reaching out, and we're very delighted when they do. This has also been adapted in Nova Scotia by the Reproductive Health Program there. But if anyone's got any advice or thoughts on how we might be able to better track the uptake of our pathway, I definitely would love to hear some of that input. So I'm going to talk about two other pieces of work at PCMCH. I've talked throughout my presentation about the importance of early identification. And one of the ways that we're trying to facilitate that is through the Ontario Perinatal Record. I talked about it a few minutes ago. This is the standardized form, 5-page form that is used for documenting prenatal care and immediate postpartum care for the vast majority of pregnancies in Ontario. There's about 150,000 babies born every year in Ontario. And for the majority, vast majority, I don't have an exact number of those pregnancies, this form is used by healthcare providers and then shared as patients move through their pregnancy care journey to other providers that are supporting them. So we are currently going through the process of updating this form and hoping to release it sometime this spring or this summer out of PCMCH. A couple of things that we have on this form that are important. One is we have screens for perinatal mood and anxiety disorders and other mental health conditions. So as you're sitting down as a newly pregnant person or somebody who's going through their pregnancy journey and your healthcare provider is having the conversation with you, asking you a bunch of questions, there are questions there for them to ask about and be able to assess some of these perinatal mental health concerns. We have a new screening in our updated form to ask about history of perinatal anxiety, depression, and psychosis, because we know that if you've had any of this in a previous pregnancy, you're at a higher risk of recurrence. And this is where there's an opportunity for the healthcare providers to be proactive and do some of that early detection. And then we have right into that 5-page form some validated screening tools that are built right into there, so providers don't have to go somewhere else searching for them. There's no reason for them to not do this assessment. And there's some of those listed here in my second last bullet. And then there's also a screening there, questions there related to substance use. And there's some examples of the different substances that are included. The other piece of work I wanted to highlight, and I've talked about this a little bit, so probably I won't go into too much detail again, but as PCMCH has been focusing more on inclusivity and equity within the perinatal and child health space, we have put out different resources and even looked critically at our existing resources to see where we can bring in stronger equity considerations. So we've done some work on accessibility and how to provide a better pregnancy care experience for people with disabilities, supporting healthcare providers in being aware of unconscious bias and also thinking about some of the unique needs that their patients might have so they're better able to support them, as well as providing resources for patients so they feel empowered to ask for what they need in a way that will enable them to get the care and the supports that they need. So that's our work on pregnancy and disability, but this one in particular, I put up is some of the work that we've done a couple of years ago on supporting more inclusive care for 2S LGBTQIA plus populations who are going through pregnancy. And I talked about this earlier to say that a lot of our pregnancy lingo and materials are quite gendered, and sometimes it can be isolating and difficult for people who may not identify as a pregnant woman to be able to relate to the way that they're being spoken to or the care that they're being provided, and particularly if they've got a partner who might be different than what most pregnant people might have. So for a number of reasons, we felt that it was important to put out some resources for healthcare providers, because even the most well-meaning care providers were saying to us they're not really sure how to start those conversations, and we wanted to provide them with some resources to support providing trauma-informed care that is really customized to the needs of their patients. So we did a tip sheet, and then we did some multimedia resources, some short video clips where we have healthcare providers as well as people with lived experience talking about their experiences of receiving perinatal care and really talking about what good, high quality perinatal care would look like for them as they're going through the system. So I'm going to wrap up with my last slide, or my last slide after this is just with a bit of the QR code and additional information. But all this to say, we've worked on some resources, we worked on some pathways and tip sheets and things like that. But I want to go back to recognizing that that perinatal mental health is a complex issue. We really need to think about it across different systems, not just the healthcare system. There's still lots of work to be done with respect to reducing stigma, normalizing mental health as part of the routine conversations that take place in perinatal care. It's very important to do that in order to do the early identification, early connections with the sort of supports that the patients would need. It's also important to recognize that there are equity gaps, and designing resources, co-designing them with communities, making sure that they're culturally informed would be important to make sure that we're not exacerbating equity gaps that currently exist. And then, the last little piece here is, again, a recognition that in order to provide the right care in the right place and at the right time, we do need more investment in mental health in general, but also specifically in perinatal mental health. It is a shared responsibility across multiple providers, care providers, and we need to continue to strive to work in a more coordinated fashion to support the pregnant people facing mental health concerns. And so I want to thank you for listening to me. I know the chat was popping up a few times, so I will take a look after I wrap up to see if there's anything else there. And also Sydney and Blanca can flag to me. On the left-hand side is the QR code for that 2-page mental health care pathway that I shared. Right-hand side is the link to our website. We have a quarterly newsletter that we put out that covers a lot of different topics, including when we have resources related to mental health, as well as when we're recruiting members for working groups and committees. We tend to issue public calls for expressions of interest that will be posted through our newsletter. So I encourage you to check that out as well. Thank you. With that, I'll stop and I'll turn it back to Sydney to facilitate any further conversation, if there's time.
Thank you so much, Sanober. Sanober, we'll be needing to move into our next session pretty quickly, but I did want to acknowledge some of the conversation in the chat around the challenges our programs, some programs are facing with, families having so many multi-layer challenges, and also sometimes the challenge of getting, feedback from parents in the perinatal period because of fear of child welfare interventions and things like that. And we don't have time to sort of dive into that any deeper right now, but just acknowledging that some of the conversation. There was a question from Maureen about the potential of maybe sharing some of the tip sheets that you mentioned, that perhaps if you were able to do that, I could pass them out to, send them forward to everybody. But any other final thoughts? Blanca, maybe I'll bring you on before we move on to introducing Maureen.
Oops. Thanks so much, Sanober. That was great information, and it will be great to get those resources. And I know you provided your website, which is great. And yes, acknowledging many of our projects do work with pregnant people that are involved in struggle with substances, for example. And it is a challenge to, have information sometimes because of the child welfare situation and what that all entails. So I don't know if you have any thoughts around those comments.
Yeah, I definitely don't have any quick one-line thoughts, but except to say 100% agree with what's been shared. And it's something that we are trying to work through at PCMCH, how to support pregnant people without stigmatizing, without and even creating opportunities for them to access resources privately without fear of doing that publicly, going out into a public place or walking out with a bunch of brochures, using a very specific example, versus having an app or a website or something that they can go to. And we've been spending a lot of time at PCMCH working through and thinking about the increased use of substances during pregnancy and some of the significant impacts it can have on health, and how do we support in a trauma-informed way. So nothing more except to say, there's a report from the coroner's had a special committee, the coroner's office on substance use and pregnancy, and one of our colleagues from PCMC sat on that. So we're engaged in some of those conversations. We're looking at some research and trying to collaborate on some resources for people going through pregnancy, and really mindful that we don't want to create fear and problems, and we don't want to further stigmatize or shame people. But I don't have anything else that I can offer succinctly except to say totally agree. Would love to continue the conversation if anyone would like to reach out. And for sure, we'll share the tip sheets and pathways, maybe just share the web links to them so it's easier for everybody to access them. Thank you.
Thank you. One quick question I had was around Indigenous specific content. If you have a consultative approach with Indigenous communities or an advisory, how that works.
So we do have a new role that we created at PCMCH a couple of years ago, which is a program manager for Indigenous health equity and engagement. And also about 3 years ago, PCMCH entered into a strategic partnership with the Indigenous Primary Healthcare Council. So with a couple of these key moves, we have been able to do a little bit of work. We want to do a lot more, but we've been able to do a little bit of work to provide resources and supports for Indigenous communities. We're strong proponents that Indigenous health rests in Indigenous hands. So we don't want to do any work for Indigenous communities. We want to work with them, and we really want to, without them being at the table and really driving that work and leading that work. So a lot of the work that we're doing or contemplating doing, it is with lots of input, guidance, direction from Indigenous partners. And so that RSV's resource that I talked about halfway through my presentation when I had the picture on the slide with some of our different resources, that particular RSV immunization resource, we did do an adaptation of that with the Indigenous Primary Healthcare Council and translated that particular resource into 4 Indigenous languages, customized the artwork, and make sure that it went through a review with a number of Indigenous community partners so that it would be relevant and appropriate. So that's just one example. And then there's a bunch of other things that we're trying to do in the space. But again, I would say same thing, right? There's the huge, bigger system shifts and addressing embedded biases and colonial constructs, while also, I would say, trying to see what we can do more quickly that's responsive to some immediate needs. So this is where we're having some conversations around work related to resources for around substance use and pregnancy and what that means. That's just one example. Some of the immunization work we've been able to do. So I'm so mindful. I don't want to cut into Maureen's time anymore, but you're raising great questions that I feel require a whole other hour for us to really delve into it together.
Thank you. Okay, so we are going to move on. I just want to do a quick intro. She doesn't need an introduction, but I'm just going to do it for Maureen. So Maureen Hampton has worked with Connections, a CAPCHP project, for over 20 years. Her background includes nursing, business management, and social service work. She brings extensive experience supporting vulnerable families through one-on-one engagement, group facilitation, program development, and grant writing. Maureen's work is grounded in a trauma-informed, strength-based approach, and she is deeply committed to building meaningful connections that support maternal and family well-being. Thanks for doing this today, Maureen. Looking forward
you're welcome.
to your presentation on the maternal mental health toolkit.
All right. If people want to take a little break, just go use the washroom or something, I'm just going to set up my screen. So this will be a good time for people to go if they need to go. And I'll just switch over here. Okay, so I share screen.
I'm with you here, Maureen. If you need anything,
Thank
I'm
you.
just switching
Thank
the
goodness.
spotlights, making sure you're spotlighted and taking it off Sanober.
How's that screen?
Oh, no, we're not seeing you at all. So I think you need to hit the share first. Did you?
Okay, I thought I had, but maybe I didn't. Okay, hang on.
No worries.
Hmm. Try that again.
Okay, we're getting something.
You got something now?
It's coming up. It's not
Okay.
quite there yet.
Oh, there we go.
Okay, so now we
And
see your
then,
program,
all
right?
right. And then we'll get me on the presenter view.
Yes,
How's that?
that's perfect.
Okay, great. Super. And I just want to shrink. Ah, there we go. Okay, super. So thank you everybody for having me to the refresher training on the Mother's Mental Health Toolkit. Just want to be able to see a couple of people, just trying to see what button I push here for that. Hmm.
Do you want me to remove your spotlight?
No, just because I like the screen to be large, but I thought it would be nice if I could see a couple of people, but it's not that big a deal.
Not
Maybe I
working.
can. Oh, well, that's okay. So I just wanted to say that was a great presentation from Sanober, very informative and a good reminder to us about language we use around, birthing parents and that. And we were actually talking about this the other day at work. So thank you for that. So let's see here. Blanca gave me that wonderful intro. Well, thank you very much. I have worked for a CAPCHP project for 25 years this month. So it was life-changing for me when I started many years ago, and I still enjoy my work a great deal. Yeah. So I'm just outside of Ottawa. I work in a project called Connections, and it's in Carleton Place. If you want to ask any questions on the chat, please do so. If you have a question, Sydney will bring it to my attention because I don't mind answering as we go. And at the end, we'll have a few minutes to have a discussion about anything that you'd like to talk about. So if you have a piece of paper, you can write down some questions for the end. That would be great. So we're going to start with a survey that Sydney's going to put out just to see how many people have worked with this kit or are familiar with it.
Yes. Okay, we've got oh, excuse me, my voice started to crack there. We've got a little poll here that I'm launching right now. So you should see it, yes? People are responding. Give it another 30 seconds or so. Before today, how familiar are you with the Mother's Mental Health Toolkit? Another couple of seconds. I think we've got almost everybody's participated, 80%. So give you another moment to hit send if you haven't already. Okay. I'm not sure if you're seeing the results as they come up, but I will end
No,
the poll
I'm not.
and then, okay. So I'll end the poll and share the results. Boom. You should be seeing it now. Do you see it, Maureen?
Okay. Yes. All right. Well, that's great. So I won't be repeating to a lot of you, which is good. I'm glad people have heard of it. So 40%, that's a great number, and but never used it. So this is definitely an introduction to it, and for those that have used it before, it'll be a good reminder of what pages are out there. That's great. Thank you, Sydney.
You're welcome.
All right, so screen one. So the Mother's Mental Health Toolkit was developed by Joanne McDonald and Colleen Flynn in Nova Scotia. We went down, and I think it was 2012, to do the training, and it was a great training. We spent a few days there and learned a lot from these women. And this in particular has been one of my favorite toolkits to use. And there have been a number of toolkits that are great, though, that Public Health Agency of Canada has helped develop. Excuse my cough. So what is the Mother's Mental Health Toolkit? It's an agency resource for community service providers and mothers they work with. And using the proper language, I guess we should be saying a birthing parent. So please take that in consideration when I use the word mother. It's used for an education, advocacy, and treatment purpose, and it is to support mothers and parents who may identify with having mental health problems. This tool should not be given to a mother for use on her own. It's a tool to be used together with a service provider. Really encourage that, because there are things that a mother may not understand from our perspective. So really recommend that we don't give it out to moms. So we'll just start with a little bit of data that I've collected here, maybe a little bit of a repeat from our last presentation, but we've had a significant increase in mental health concerns since the pandemic, and so we know that that there's been an increase since COVID, and our families have certainly identified that to us. And with the high number of 30% increase, we know that the women coming to our programs are all within this age group, and also likely to be already dealing with anxiety or depression. And of course, we know women are twice as likely as men to experience anxiety disorders. This is an important consideration for us to note. I don't want to read the screens for you, so I'll let you read them, and then we can comment on them. And the economic pressures that we're dealing with now, all of us, the high cost of food, the high cost of gas is taking a toll on the families we support, for sure. And us, because we often supply transportation and whatnot. So I think costs are going up. Just for definition purposes, the perinatal period includes conception till 1 year postnatal. Many of the women that come to us don't understand necessarily what they're experiencing. Example, a woman who identifies she is suffering with intrusive thoughts may not know that she may have obsessive compulsive disorder. She might just be tormented by the thoughts and confused, and may think it's only her that ever experiences this. So we have to always remember that and we'll get into some of those barriers. Yeah. So I think Sanober had a 22%, so I had 23% of new mothers in Canada, higher rates among mothers under 25, marginalized groups, and those with adverse life experiences or anxiety, which is definitely a description of the families we serve. Postpartum depression symptoms are related to these factors, and many of the women we serve, if not all, have a history of these things during pregnancy. Not all, but some. I would say most in our project. Pregnancy can be a hard thing to cope with in itself, especially if we're working with women who have a history of sexual abuse, sexual trauma. We know there are effects on children if a parent has a mental health problem, disorder in the home, and it can definitely impact the well-being of their children, particularly those under the age of 6. As you can see here, it can impact low birth weights, preterm birth, and the increased risk of mental health problems later in the child's life. Tell me if I'm going too quick here. Women's mental health in Canada is shaped by biological, social, and economic factors. Very true. We need to keep working together to support women. A key component of the work we do in our Ontario projects is community development and inclusivity with community partners. All right, so we're going to get into the barriers for women seeking help. We have our families that we serve in our projects have significant barriers at times, and some more than others. They have often have limited understanding of what a mental health issue is. They may have a diagnosis of something, but they're quite, willing to share that with us, but they may not realize they have dual diagnosis or other things that they may or may not be could be diagnosed with. They're always not aware of their options for support. Often we are the first point of support in a community for any at-risk parent who may not have seen their doctor yet. We deal with women who have had no prenatal care, and so we need to, really be aware of that. Often women come in with low self-esteem. They tell us that in our group often, and they have limited finances and transportation. We live in a rural area, so we pay for transportation, and it's a huge part of our budget as we don't have bus service, so we can't give bus passes. Just want to emphasize that a barrier for women seeking help is interpersonal violence or violence against women. That is something we really need to just pay attention to in our groups or in our projects, because it is significant. And also the fear of child protection services. Many women are afraid of labels because they think that will lead instantly to having a family and child service worker or actual apprehension. So to explore the mental health kit, does anyone have any questions about the data that I shared? Okay. So the Mother's Mental Health Toolkit has a really nice layout. It's user-friendly. The chapters are color-coded, and there's pages for service providers and pages for mothers. The service provider pages provide guidance, information, screening tools, and advocacy ideas for workers. Again, not shared typically with our participants. Mother pages use questions, information, and screening tools for the participant. For individual or group work, we suggest printing them in color because they are more likely to engage and fill them out. Again, to note, it is not a diagnostic tool, nor is it a treatment manual. This is for individual work with a frontline worker or service provider, and to be used in group work, which we do a lot, and we'll talk a bit about that. So, Chapter 1, Wellness and Self-Care. If a woman is unaware she needs to practice self-care and self-compassion, she may be more prone to illness and mental health symptoms. A great way to help women learn that self-care is not only taking a bubble bath. This is a great chapter with great pages that we can share with them and teach them about self-care and self-compassion. This chapter provides worksheets that discuss medical care, substance use, nutrition, stress reduction, and sleep quality, all part of the self-care, self-compassion family. So I'm going to share each chapter. I'll share a couple of pages that I like and that we can use. Page 15 is a great starting point for discovery. Does the mother engage in self-care? Does she value it? Does she understand it? This sheet helps identifies what the mother needs. One question about self-esteem. I am often asked by women to help them learn how to increase their self-esteem. We do this in our Making the Connection group, which is a connections program developed by Breaking the Cycle in Toronto. They call it Connections, but because that's our agency name, we've called the group Making the Connection. Can everybody read the screen okay? Like the checklists and that? I know they're a bit small.
It's a little small, but
yeah. I guess you could maybe zoom your own screen. I'm not sure. But like one of the first question is, how are you doing now under nutrition food? Do you think you're eating well? Often people in general don't really realize that nutrition is part of self-care, feeding ourselves nutrient-dense food, and so that we can stay well and have more energy for ourselves and for our children. So these kind of questions. And it also talks about, do you want to learn more about it? And would you like help with this? So it's a great tool if they fill it out for us to see where they're at. Another sheet that I really like is page 43. It's called Who I Am. It's interesting that it looks like it's been scrumpled up and kind of tossed out, because women struggle with this. When we ask this, we use this page in our groups, and when we prompt the women to identify components of themselves, most of them say, I am a mother or I am a partner. And that is solely how they identify who I am. So these questions help women to identify components of themselves: personal virtues, values, dreams, and what brings them joy.
Maureen, there's a question
Yeah,
in the chat. Dawn
great.
is acknowledging that their toolkit is from 2012 and wondering if there's an updated version. Do you
That's a
know the
great.
latest version date? I don't myself.
2012, I believe, is the latest version date. But
Right.
I have reached out to the project and not heard back yet. But I was wondering if they'd be interested in doing an update, or maybe we could at some point, get that done, because I think it would be really useful for sure. Thanks for
Yes,
that
and not
question.
to, I
Great
won't
question.
divert too much, but I will acknowledge we did have the creators come and speak to our conference a couple of years ago, and they talked
Okay.
about that sort of what bringing it into now. But anyway, I'll
Okay,
post a
great.
link to that in the chat.
Okay, great.
Yeah,
Because like I am the Eastern rep, and I've never heard of any, and I have been since 2012, so I haven't heard of
yeah.
any update, but I hope I'm not wrong. But definitely that's something worth looking into. All right, so
Thank you.
chapter 2 is the mothering role. It's basically a chapter to help us support mom in learning to be a parent. Pages include a review for service providers on what attachment is and the 4 patterns of secure, ambivalent, resistant, avoidant, and disorganized attachment. We'll get into an example here. What babies have to say to us. So page 54, this is an action page. Examples help develop attachment with the baby during the first year of life. It's like the baby is talking to the mother, which they seem to really like. It includes key suggestions to ponder, such as think about what I need when I turn away, or I am upset by people I don't know. When they read this, or we read out loud to them, or we read out loud taking turns in group, it's like they say, "Oh, I didn't know that about my baby. I didn't know that's something my baby would want. I didn't know that's why she gets upset when I give her to a stranger." So this is a great page for moms to learn from. This is actually my favorite page in the book. Kind of sounds silly because it's very simple, and it's a great page for the fridge. It's simple but effective. We help identify supports like doctors, therapists, friends, neighbors, family, and of course, us. We help her to identify who she could call in certain situations like loneliness, distress, or seeking support for food, etc. Or it might be just for her to have fun with. That's important that we help her incorporate that support isn't just for crisis, it is for maybe going to a movie, or having swapping childcare with another mom. So we can do one for them, and we can also do one for their children if they're interested in that as well. So this is a great resource, and I've never seen a mother not want to start filling it out. They do get stuck on it, but easy to fill it in for them, and for them to use it. Page 48, Many Hats of Motherhood. Help moms identify all she does within her mother role. Um, we work with a lot of women that are experiencing domestic violence, and they tell us that, their partner doesn't think they do anything all day. And so this really helps them realize that we are recognizing what they do every day, and that now she can recognize what she does every day. Mother as a provider, a caregiver, an educator, a cook, a taxi driver, so many things, caregiver, and a protector, of course. So they really like this one too. And sometimes we uh, ask them, what their favorite hat is, and did they recognize was there any hats that they didn't realize that's what they did. So it's a great tool, again, to get discussion going, especially if you have a mother that's quiet and, really you have to pull information from. These sheets can really help with that. The last one I'll share here is common thoughts about motherhood. They love the true and false questions because they're easy, and always being aware that reading levels are different amongst the parents that we serve. So if we're in a group setting, I always like to say I can read it out loud, or maybe we can take turns and you can pass if you don't want to read. So most mothers will try, even some of our low literate parents will try and read for us, so which is great. But it does identify false beliefs and lessons and less burden on the mother of being a perfect mother. I think one of them say they're wanting, what is it? Mothers have to be perfect, or their children will grow up to hate them. So just getting rid of those kind of false information for the mom is really important. And this, again, these tools are great for that. Oh, I had one more page, I guess. Building a strong bond with your baby. Tips on bonding. You can't spoil a baby. How often do we hear our mothers say to us, or the dads, my mom says I'm spoiling the baby. My sister says I'm spoiling the baby. They're telling me to sleep train. So this is where this can come in, because it isn't just coming from us, it's coming from this booklet. And it's telling them, no, you can't spoil a baby, and you're supposed to pick up your baby when they cry. And we always tell them that now you're the mother, not the daughter or the sister, but now you're the most important role of your motherhood is being the mom. So you're in charge of what you do with your baby, and it teaches them to be assertive, and also teaches them that they don't have to be perfect once again. All right, so chapter 3, this is the chapter I would say, chapter 1 and chapter 3 are the chapters we use the most. It's a three-dimensional perspective, including the body, the thinking, and the feelings of the parent that we're working with. Helps the mom see her body, mind as a tool to change patterns. Seeing things in a different way may help to bring more joy to her. I think sometimes we underestimate how far a little bit of joy in a person's life can reduce depression and reduce anxiety. And I think it's important that we encourage women to consider joy as part of their list of things to have that day or in that week or in that month. And sometimes they don't know what brings them joy, so we can help them identify that. This chapter has a high focus on domestic violence. As we know, since COVID, again, more and more women are experiencing domestic violence. And we just recently had, in Alberta, a mother lost her 2 children with a visit with the father. So this is something we're seeing a lot more of. And these pages are a really good tool, especially for service providers who may be a little bit uncomfortable with talking about it. So we can talk a bit about that. And there's pages in here too that help mothers understand that baby blues is not postpartum depression. So things like that. So this page, understanding IPV or domestic violence is important for service providers. I was a domestic violence worker for over 25 years, and I learned very quickly that our projects serve the same women in shelter as the shelters do and the outreach services do. Sometimes I'm shocked that when I was working there, how a mom would be in one group and also in a group there, and yet I didn't have any idea of that when she was working with us at Connections. So always keep in mind that stats will probably come in very low of how many women are actually dealing with this. And I say mothers because that's who we're dealing with today versus men. I realize that men also experience abuse. Being able to discuss the topic with women is so important. I've heard women say they never disclose it because no one ever talked to them about it or asked them about it. Opening a discussion can be as simple as, does your partner yell at you? Does your partner call you names when he becomes angry? Do you walk on eggshells when your partner's around? And this can lead to, I have a great questionnaire for you and we can do it together. Has a great list of questions. The only thing I caution you with is I don't personally use the scorecard at the bottom here because it feels over-focused on physical abuse. In fact, we know that men who kill their partners often have never hit their partner prior. So that is a false thing that if abuse is only physical or sexual, and we work hard at teaching women that emotional abuse is sometimes more damaging than the physical abuse because it's long-lasting and sometimes never leaves. But if anyone needs any information on how to talk to women about domestic violence, please reach out to me at any time, or you can reach out to your local shelter, or and they may have someone that can come and talk to your team or talk to you individually. Never be afraid to ask, though. Happy to share. This is our power and control wheel. Most of you have probably seen this before. It's a great tool, and in this book particularly, there are 3 wheels in this book used for different cultural groups. This is page 121. It's a mental health checkup list. This is great for mood and or mental health symptoms. It can help us determine if our participant may need a referral to a doctor or a therapist. This chapter contains a sheet for mothers to take to their doctor with their questions. However, one time a woman did that and he just said he wasn't going to look at her list because he only dealt with one circumstance at a time. So I felt really bad that I'd advised her to take this page in, but I said to her, it's okay that you did that. So it's still something I stand by, and I think it's a good thing. And we aren't one problem people, especially young mothers or mothers that are pregnant or in high risk pregnancy states. They're not a one question kind of appointment person. Other sheets define postpartum mental health disorders. Again, the baby blues versus PPD. And there's some great service provider sheets as well on risk factors for mental health problems during pregnancy and postpartum. Okay, chapter 4 is an assessment screening. This is a great resource for cultural awareness, adding value to our client-worker relationships. Being aware of these ideas can help us become better workers. Developing the cultural awareness, differences exist. Service providers have their own cultural beliefs, and we can sometimes bring in our own biases. Cultural ideas of mental health and mental illness can vary amongst different groups, and responses to these can vary. So it's important that we educate ourselves, and this book has a great start to that. But I know we at Connections are working more and more with newcomers, and we are getting ourselves educated on just the different cultural ideas of mental health and mental wellness too. So okay. So this page is again gives tips on how to build our cultural competence and improve our communication skills, building stronger relationships with women, newcomers, and from women with diverse backgrounds. And very important, just in our body language, or how loud we speak, or just even like eye contact can make a difference for a woman to share. This is page 137. It's a mother's page. It's a postpartum checklist, a great place to start and help us know if we need to make a referral. Questions like, am I less interested in things that used to interest me? That's a great question. So you can expand on some of these and get more information from them. Am I too worried or too detached regarding the baby? Is my anxiety getting in the way of doing what I need to do? So again, really great questions and easy for them to answer because they basically are a yes and no, and you can explore the tick marks with them and which one they feel the most concerned about if you have limited time. And chapter 5. Okay, we're moving here pretty quickly. I hope I'm not going too fast, but chapter 5 is intervention and treatments. This is a chapter for service providers only. It has, again, general interventions, normalize and encouragement, therapy principles, examples of types of therapy, and medications, differences and side effects. One of the pages is, so these are the therapy principles. Again, just an overview. This one is types of therapy, an overview. Keeping in mind that description and practices may vary now, as this was 2012 information. Chapter 6, supporting recovery. As we know, a lot of the women we serve and parents we serve are parenting while using substance, and helping them to safely do that, or helping them to safely understand the risk factors for their children. If there were, substance in the home, that kind of thing, we often give out lock boxes for them, and they tell us that they use it and they feel better about that, that they have somewhere to put something where the children can't access it. Helping a mom organize her recovery is a big task, and it's not something we can do alone in our project. We need, assistance from other agencies, doctors, and other community agency people, right? So we like, I know where we live, we have some great people that we can contact and get support, because often mothers that come to see us, or fathers even, they don't want to work with anyone else at the beginning. They just want our help. So it's these kind of tools can help. I'll show you an example. So tracking our symptoms worksheet, it helps participants assess her own experiences and thoughts that may lead to her substance use. This helps her evaluate her coping responses with the guidance of you, the service provider. And we use this in group, and we often give our own example of something that would, an experience that might heighten our ability to, want to use a coping mechanism of some form. So we try to, if they can't come up with an idea, we'll give them another example of like the one up here. This one is Healthy Thinking Workshop. Helping a mother identify her thought patterns, including distortions in thinking, really important. Helping women learn to, switch the dialect in her head can be, a really great tool if we can help her learn that. A good example is providing for her to see how her thinking patterns work and may benefit from change. So she may have a thought of, I'm a complete failure at everything in my life. That is an all or nothing example of a distortion. And so we can help clarify that none of us do everything well, but failure is a strong word. And then even go on to say failure is okay because it's part of building our self-esteem, having the confidence to try something new, even if we fail at it. We still tried, and that's what we need to focus on. And that raises our self-esteem. So trying to get rid of words like failure. And then asking her questions like, what would your best friend say? What would, um, are you ignoring for yourself some of the positive things you have done? And then she may say things like, I am really good at some things in my life. Just because I made a mistake and can't do everything really, really well doesn't mean I am a complete failure. So by the end of each box, we've already switched some of her thinking. And again, we use this individually with women and for group work. This is an important page, page 158. It's a tip sheet for mothers whose children have been taken out of their care or uh, are, potentially going to be taken out of their care, or even just working with FCS worker, and maybe they may have to go to court or something. So points like 5 or number 6, keeping good records or going to court, sets them up for success versus failure. When I have a woman who is have FCS involved now, I give them a booklet and I ask them to make sure they keep a record of all visits, all conversations, so that they have a history, because sometimes they can work with them for quite a long time and then it goes to court. And if they have no history and don't have good memory, they might feel very lost. So a notebook is simple. We get them at the dollar store, and moms seem to really like that. A mother's fear of child apprehension can halt recovery. Absolutely. Even having children's aid or family services get involved I see can increase the risk of relapse and more risky behaviors. We see that, and women tell us about that. So chapter 7, the final chapter, again for service providers only. It's about collaborative care. It talks about the need to work in multidisciplinary teams, gives lists of ideas and suggestions for collaborative and mental health care. Of course, the CAPCHP groups have been doing this since the beginning, and that is one of our things that we work very hard at as community partners, and that wraparound team approach for the families we serve. So I thought I'd just show you a little quick case study on possible health diagnosis. This, for some reason, this is a fancy screen, so bear with me. Panic disorder, a panic attack, is a sudden episode of intense fear that triggers severe physical reactions when there is no real danger or apparent cause. Panic attacks can be very frightening. When panic attacks occur, you might think you're losing control, having a heart attack, or even dying. So if a woman presents to us that this is something she's dealing with, she may not know that it's panic disorder. She just may say, I feel like I'm panicking all the time. She may not have a formal diagnosis, which is okay. We don't need to have a formal diagnosis to start addressing some of it, and then possibly making a referral if we feel that's, would be in her best interest. So like page 56 is for service providers. It's strategies for coping. So it gives us a refresher course in what we can offer for coping ideas. Page 57, 58, and 59 is kind of a sheet that helps ourselves to calm, actually giving examples of skills such as mindfulness and imagery. Those little squeeze balls or anything to just, deep breathing. We talk about that, and it just helps them, bring it down a level so that they can, take in some of the information that they need to reduce their panic episodes. And often when they start talking about it, panic starts to set in, and they almost feel like they're going into a panic attack. In chapter 3, the pages 120 to 129 are mental health checklists and defining what mental health is. So again, this is how we would, if I had a woman that suffered from a certain thing, I would look up pages to use with her. Not always and not every client, obviously, but certainly for group work, if a woman tells us she has this or doesn't really understand mental health, we'll be sure to make sure that this sheet gets put into the binder, even if we add it the following week, just so women can use it. And we do find women are using the sheets for homework and then bringing them back to group and asking questions about them, which is great. So the Mother's Mental Health Toolkit is simply that, just a tool. It supports us in supporting women and their families in the understanding of mother's mental health. Thank you. I'm happy to take any questions. If you would like one of the Mother's Mental Health Toolkits, I am happy to send them to you. I have quite a few of them, and I have a link here for the worksheets, but some of the worksheets are not in there, and so you need the book to photocopy from. So if that's something you'd like, please just email me at mhampton@connectwell.ca, and I'll ship one off to you. And if you need more than one, that's not a problem.
That is
so maybe
awesome that you have physical copies that you can send folks.
Yeah, I have quite a few boxes of them actually. They sent quite a few of them to me because they couldn't store them, so I have quite a few. And you know, even if some of it is outdated, the sheets can still be used. So
For sure.
for a lot of it, it's more the language and that kind of thing. But even then, I didn't find, you know, too many things I was concerned about. Some of the stats that they had given me are outdated, so I redid this, you know, stats and making sure we have up-to-date data. But okay, so I'll take myself off here and so how do I do that? Okay, here we go. And maybe oops, maybe we can answer some questions.
Oh, oh good, you stopped sharing. That's great.
There we go.
There we go.
Lots of chat things here, I see, eh?
Definitely. And Lee put your email address in the chat because she's awesome.
Oh, thank you, Lee.
So if you would like to reach out to Maureen.
Yeah, and I would just like to give a shout out to Lee for her support in helping me build this deck, and of course to Sydney and Blanca for you know, getting this together and always being a great support to me, Sydney.
Thank you
Right.
for
Anybody want to ask some questions?
yeah.
And you can ask questions about the Mother's Mental Health Toolkit, or if you have any questions about talking to women about domestic violence, you know, I'm happy to answer a few of those too.
Well, I guess the question I have, like, it seems to me from what you were saying that like you pull from the toolkit to supplement the groups and programs that you're offering, right? It doesn't necessarily that we are doing a Mother's Mental Health Toolkit program specifically.
Yeah.
It's that it's a resource for all your
Staff.
yeah.
Some others we wouldn't use that with. They wouldn't be interested in something like that.
Yep.
But I find if you're working with a mom that's really hard to get information from, yes and no answers, doesn't really want to, you know, she wants to talk, but she doesn't really know how to talk, or she's afraid of breaking down. These can be a great, you know, I got a great questionnaire. Let's start with that. And then we can help them expand on their check marks and that. So it can be a great tool. And I find for group work, they're great sheets to do together. And we do them in our Making the Connection group, which is the group that connections group from Breaking the Cycle that we were trained in. So we do a lot on self-care in that, and we do a lot on you know, identifying who we are as women, because again, if a mom is only saying I'm a mother and I'm a partner, you know, that isn't who she is. Those are roles that she has, right? And so it's important for us to make sure they understand some of their own qualities, some of their own values, their virtues, and what they have to offer as an individual versus as a mother or partner.
Thank you, because it's so great to have you here taking us through the toolkit. It is such a valuable resource, and we are acknowledging that it's perhaps getting a little dated, and we might need to just pay attention to, statistics, or, are thinking about inclusive language as we're using it. But that certainly doesn't mean it's not something that is still of great value to our projects. And some people may not know this, but that it was actually, built with CAPC and CPMP in
Yes.
mind, right?
Yes, from all
So,
of the families, a lot of women took part in that right across Canada in developing the worksheets and how to talk to moms, for sure.
So, unless there are any more questions, I want to offer my gratitude, my big gratitude to you, Maureen, for being willing to take us through and show us the value of this resource that's so readily available to us. And to Sanober, thank you so much for giving us that broad provincial perspective on the work that is being done by the council. I think having you two coming and joining us today has been a really great way to acknowledge World Maternal Mental Health Day. It's very, very important. So to have both of those sort of, system-wide and also on the ground service supports has been really helpful. Blanca, do you have any final words that you'd like to share as we wrap
I
up?
just wanted to echo the gratitude for Sanober and Maureen for taking the time and sharing your knowledge and expertise. I was saying to Sanober, you have an open invitation anytime you want to connect
Yes.
to find out more about our CAPCHP, our network. Give us a shout, and we're happy to do that. And to Maureen, thank you. We can always count on you, to walk us through this great resource that's been around for a long time, but it's so important to sort of loop back, because we have, as we know, many new staff. And it's important that we keep that resource, which is a good resource. It needs an update, but it's still like a really great resource. So thank you so much. I put on the chat the website for the World Maternal Mental Health Awareness Day. It
Excellent.
has good resources, other information about other events, and how to get involved. So Canada does not have a perinatal perinatal mental health strategy. And I think that's something that many of us keep working towards and advocating for. So gotta keep on keeping on.
Blanca, if I could just say, if people could email me directly, I may not get all your email, like your requests on here. So if you want one, please email me directly at mhampton@connectwell.ca. Thank you. Sorry.
Thanks, Marie.
Sounds good.
And
thank you, Blanca. We'll thank each other simultaneously. It's always such a pleasure for us to organize this event together, both the network and the Ontario Region Office. And that is bringing us to a close. And I did put in the chat a link to a very short 2-minute survey that I hope you'll take a moment to fill out and just give us some feedback on today's event. It always helps us in planning our gatherings. And keep your eyes open for our next event. I believe will be a father-focused event in June. We're starting to get the planning for that underway. So keep an eye open in the newsletter and on WebConnects for more information. And with that, final gratitude to our speakers, to Blanca, and to all of you for joining us today. I hope the rest of your week goes well, and that I will see you soon.
Thanks, Sydney. Bye, Blanca.
Bye.
Thank you, everybody.
Bye.
Bye-bye.